Hello everyone. This is the first part of the drugs that affect the endocrine system. Probably do a couple parts. Make sure you listen to all of them here. First off, I want to say that we are going to be going into some stuff in this presentation that is not going to necessarily be on my exam. So I will make note of that. So just a quick heads up. Specifically, there's going to be some hormones and some medications that are used for diagnostic purposes only. So I won't have exam questions for this module on drugs that just, or hormones that are just for diagnostic purposes. So, and I'll make note of those once we go through those. So let's just jump into it. Part 1, hypothalamus and pituitary. General considerations, probably heard this in pathophys, maybe even ICM. But basically hormones are chemical messengers, right? So, and these are, secreted by one tissue or gland, and then it's to communicate with another part of the body or to have a desired effect. And then when it's pathological, sometimes an undesirable effect, right? So from a pharmacological standpoint, they use these hormones and their synthetic analogs, which I'll note those once we go through them, for a few different things. So this first one, the diagnostic tools and endocrine disorders, those are the ones that I will not have test questions on, but we'll have test questions when it talks about replacement therapy, endocrine disorders, and then treatment of non-endocrine disorders. Stay tuned for those. This is just showing a relationship between some hormones in the body and a negative feedback loop. Mostly in the body, there are negative feedback loops. Occasionally there are positive feedback loops. It's rare. One is, childbirth that comes to mind. But again, that'll be more topics that you guys will cover in pathophysiology. So don't stress too much for my exam in having to memorize this slide or whatever. It's just showing, just an example of positive and negative effects. This table as well, don't stress too much about it. It's showing just, where the target organ is for some of these hormones, and then the target organ hormones specifically. So what organs and then what hormones are going to be involved. This may help you with studying for some of the mechanism of action. So, but as far as memorizing this table and just being able to regurgitate for testing purposes, for my exam, don't worry about it. But I believe this will be relevant for pathophysiology at least. So ask about that. All right, here we're getting into some of the drugs, some hormones here, specifically the ones for the hypothalamic region of your body. First off, we have Sermorelin. This is a growth hormone releasing hormone, which is kind of a tongue twister there, but so this one actually causes rapid elevation of growth hormone. So it can be used anytime, or for its use then, if you have a deficiency of growth hormone, this can be used for that. And then it also can be used diagnostically too. But so again, we're studying for my exam, just worry then, just have this drug on your charts, that it basically causes, mechanism of action and causes the release of growth hormone, and then it is used for growth hormone deficiencies. Somatostatin. So this is a growth hormone inhibiting hormone. So this inhibits GH, which growth hormone, by the way, is abbreviated GH. Octreotide is the actual medication or the drug. It's a synthetic analog. So the somatostatin is what is in your body and occurs naturally for the majority of humans. And then the octreotide is going to be what you can actually prescribe. So as far as mechanism of action concerns, pretty quick, pretty easy. It does inhibit the release of pituitary hormones because it is and it also inhibits release of some of the GI hormones. So because of that, it has a number of different uses. You'll notice some are GI on the bottom, but the majority are going to be cancer related. One of the uses that's not on here that you go ahead and should definitely add to the slide is acromegaly. And let me just, one sec. I just realized I haven't given you guys these slides yet, so I'll just edit the slide for you before telling you to add that. So acromegaly is a use for this medication. Other thing is going to be, like I mentioned, cancer, but so carcinoid tumors, and then also vasoactive intestinal peptide secreting tumors. Other than that, they have some off-label uses. You notice the esophageal varices is one, ZE, the Zollinger-Ellison syndrome is another one, but there's a ton of off-label uses, so I'm not going to go through those. It's sometimes too given other than just a couple I'm going to mention here, but it sometimes is given for diarrhea that is secondary to chemotherapy. So you, again, I kind of tend to think of this as being a cancer drug, even though it's not strictly, and we have it here in the endocrine module. But anyway, so acromegaly definitely, and then other than that, cancers, specific types of tumors, and then even things that are related to cancer. So diarrhea associated with chemotherapy can help with that. Also diarrhea associated with AIDS or secondary to AIDS, but so that's pretty much it as far as its uses. Just know that if you do look it up, there are a ton of off-label uses. So if you're interested in this drug, you can, by all means go through it and look through it. But for testing purposes, just know acromegaly, cancer, and then some GI uses, ZE and the esophageal varices, in addition to diarrhea associated with chemotherapy and AIDS. Adverse effects. So I have a few here that are listed as the most common adverse effects. GI adverse effects, so diarrhea, abdominal pain, which is interesting because it can actually be beneficial or can help with treating diarrhea secondary to chemotherapy and AIDS, which is kind of seems counterintuitive, but just know when you're studying for this, GI adverse effects are common with this. So this is going to be the most common. So definitely you can just put a big GI on this slide. Other than that, you can have some CNS adverse effects, so headache, some fatigue, maybe dizziness, malaise. Also, you can have some cardiovascular adverse effects, and again, it's going to kind of depend on the patient, but just in general, you can have issues with bradycardia, chest pain, hypertension, some things like that. So, but big take-home point, GI adverse effects, those are going to be your most common. But also, too, if you look this drug up, there's a laundry list. There's a long list of adverse effects for this drug. So this is not the end-all be-all, but definitely GI adverse effects are the ones you're going to definitely want to think about when you are prescribing or using this medication. Protorelin, aka TRH, which is thyrotropin-releasing hormone. So, and more commonly referred to as TRH, by the way. I know I didn't put that at the top of the slide, but just know that you more likely will hear this being referred just as TRH. It's less commonly referred to as by this name up here. But anyways, this stimulates synthesis and release of the thyrotropin, which is, it's partly in its name, thyrotropin-releasing hormone, right? And also prolactin from the anterior pituitary. This one, again, will just be FY for my exam. Because its uses here, you'll notice it is used for diagnostic problems, or diagnosing problems, I guess is what I should say. So to assess thyroid function specifically. So anyways, so this one is just more of FY for my exam. So I'm kind of hesitant when I do this, but because I don't want you guys to think it's not important, you'll never see it. But I know this is a big presentation, and in the past, students have asked me for guidance as far as what to focus on. So, and I get that. I remember being a student, and there are a lot. It seems like a lot of stuff in this presentation. Let alone you have all the diabetes drugs. there's a lot of stuff going on in this module. Again, just if you can, just put FYI on some of these slides that I'm saying FYI to, but at least still read through them, look at them, and may still be on your board exams, and you may still see them out on rotations. But like I said, I'm trying to help you guys and make this a little bit more focused for studying purposes. Next up, we have CRH, which is also known as corticotropin-releasing hormone, which explains what it does, but it's also known as, aka corticorelin. So this one, like what the name says, it stimulates release of corticotropin and beta endorphin from the anterior pituitary. Again, put an FY here because this is primarily used for diagnostic purposes. So you can go and read through that. Interesting stuff. Definitely stuff you'll probably be seeing and covering in pathophysiology. But for studying purposes for my exam, don't stress about this one. Next up, we have the GnRH, gonadotropin-releasing hormone, and the related preparations. So these, they work by stimulating the secretion of FSH and LH, which we'll talk about a little bit more in detail here, and I believe is going to be a review from pathophysiology. And that's basically what they do. You can break this into two categorizations as far as their uses. You have the shorter acting preparations, which is just this one on the top here. So I just have it listed here. It's gonadorelin. Gotta make sure I say that correctly. Gonadorelin. And this is the only one that's categorized as a shorter acting preparation. So yes, please know the difference between shorter acting and longer acting. And this one can help with delayed puberty. It also has some fertility uses. So again, depending on where you're working, you may see this being used in fertility clinics, and just kind of depending on where you land. And then we have the longer acting, which again, yeah, important to know which ones are which. And these are a little bit different as far as their uses. You notice prostate cancer is listed here, precocious puberty, endometriosis. And go ahead and read through those. Also breast cancer. So some little bit differences depending on if it's a long acting or a short acting GnRH analog. Here we talked about the diagnostic uses of it, so don't worry about this when you're studying for this drug. Focus on those other uses we have, but it can also be used for diagnostic purposes. So you can go ahead and read through this, and helps you with your diagnosing. And like I said, you may have these diagnostic types questions. I know in the past Dr. Faruqi has used these or similar questions like this on his pathophysiology. So definitely so check with the other professors as far as if you're responsible for this information for them. Adverse effects here, just some common ones here that can happen. Menopausal symptoms for women, amenorrhea for women, and then the testicular atrophy for men. Then we have the GnRH antagonist, which they antagonize or do the opposite. But these a couple drugs here, they have some uses here. You just go and read through those. And then a summary table. So like you guys have seen from me before, please go ahead and study and look through these. Look at the clinical applications, adverse effects, and contraindications. And then also note too, like with this one right here, it's only, or rather the ones that I mentioned that were just diagnostic purposes. And FYI, just make sure that you note which ones those are, and don't have to worry about those for my exam. Next up, anterior pituitary hormones. Laundry list of those here. First off, we have the growth hormone related preparations. You can go and read through those. TSH, ACTH, FSH, LH. Lots of abbreviations here. Kind of an alphabet. Let's say apple soup. Alphabet soup is what this, I believe that's the phrase, not apple soup. But yeah, alphabet soup. So a lot of abbreviations. Please try to keep them straight, because it can get kind of confusing when you're studying and stuff. I know when I was a student, I didn't enjoy this section that much, just because I would flip letters and I'd get things mixed up, and it wasn't fun. I'd still have nightmares about that. But anyways. And I would eat apple soup and study all night long. No, I'm joking. Alphabet soup. Oh, geez. Okay, Physiology of GH, which is growth hormone. Just read through this. This is just going to be kind of a review for pathophysiology. I won't pull any test questions from this, but it's good stuff. It just basically shows you what it does, insulin-like. I mean, a lot of this I feel like is intuitive because of the name growth hormone, and then it does what? It stimulates the growth of a bone, for example. So anyways, another visual representation of what this is of what the growth hormone is doing. Again, this may be good for pathophysiology exam, but for my exam, do not worry about memorizing this. It may only be beneficial for some mechanisms of actions of some of the drugs. This may be beneficial as far as helping you study, particularly if you're a visual learner. But anyways, yeah, don't stress about that. Same thing here, pathology. This is just FYI for my course. Just know, giantism happens before puberty, and acromegaly is after puberty or after the fusion of epithelial plates of the long bones. And then we have dwarfism, which is a deficiency of GH. Fun fact, I don't know if any of you guys are Andre the Giant wrestling fans, but this won't be on the exam, but he had both giantism and acromegaly. So he's a famous wrestler from France that was like, I guess in WWF or something. Anyways, it doesn't matter. It's not on the exam. But I always think of Andre the Giant when I was studying this and when I was learning it and stuff. But anyway, so this will probably be in your patho exam, but don't worry about it for me. This one, do worry about for pharmacology. This is somatropin. This one is also known as recombinant human growth hormone, or lowercase rh, GH. So this basically, in simplest terms, as far as what it does, it opposes the actions of insulin. So kind of related to that, it's used in children with growth failure, children with short stature, children with Prader-Willi syndrome, and then it can be used in adults too. So specifically, if a person has malabsorption, if they have HIV, with cachexia maybe, or it's a wasting syndrome, and sometimes the drugs and stuff will make that worse, or if they have just some kind of growth hormone deficiency. So basically, they help they help people. I'm sorry, either children with growth deficiencies or adults who have some kind of pathological state, or one that's caused maybe secondary to some drugs, like with the HIV drugs. Adverse effects, again, long list of adverse effects. One thing to note is that the adverse effects are less likely in children than adults, but here's some of the common adverse effects that may be an issue. So the pain, arthralgia, edema, and then impaired glucose tolerance. And the impaired glucose tolerance is really with a extended use of this medication. So for longer term use, you have an increased risk of the impaired glucose tolerance. And that kind of makes sense too if you think about it. If you jump back up here to the mechanism of action, it opposes the actions of insulin. So you could see why it would have some effects on your blood glucose. Next, we have recombinant human insulin-like growth factor 1, which is also known, which is AKA Pegvisomant. So here you can be heard it called either things, but and basically the mechanism of action is that this medication is, because it's recombinant human insulin-like, it's an insulin-like growth factor 1, so IGF-1. And then it helps replace endogenous IGF-1. So you guys remember from pathophysiology, we have IGF-1 already in our body. Sometimes we have a deficiency, so this medication is used to treat that deficiency, basically. So, excuse me. So you can read through these uses here, but like I said, it's basically when there's the deficiency of endogenous IGF-1. Adverse effects here. Interesting, you can have either hyper or hypoglycemia, so please note that. And then cardiac murmur, which is a rare but serious one, and iron deficiency anemia. Again, rare but serious. Excuse me. Try not to cough on you guys. I'm trying to hit the pause and stuff and like drink herbal tea and everything, but all right. All right. Next up, we have Pegvisomant, which this one is a growth hormone receptor antagonist, and that's the best way to think about it as far as categorization goes, and then also as far as mechanism of action. So I like this last bullet point here, as far as describing how it's categorized and what it does. Its use is going to be acromegaly, and it's usually not first line, but it's if patients are unable to tolerate the other therapies. And related to that is because of the adverse effects, it can cause pain, which is very uncomfortable for patients, and then abnormal liver function test. Next up, we have thyrotropin, aka thyroid stimulating hormone, or TSH. This one actually stimulates the growth of the thyroid gland, and then it stimulates the synthesis and release of new thyroid hormones. So this one is going to be an FYI for my exam, just because you'll notice the uses there. It is used for diagnostic purposes. Believe will be relevant for pathophysiology, but just for my course, don't stress about it too much. Next up, we have the ACTH, adrenocorticotropin-related preparations. So we have a couple of those there, and ACTH, you'll remember hopefully in pathophysiology, is normally occurring in our bodies, and this regulates it. So you just read through that FYI. Mechanism of action, it stimulates growth of the adrenal gland, and it stimulates these productions of these adrenocorticoids from the adrenal gland specifically. So here are the three there. So its uses here are diagnostic, so don't worry about this for testing purposes for me, so don't worry about these slides or the ACTH for my exam, because you notice it helps identify or diagnose primary versus secondary deficiencies. Adverse effects too as well. Just these are important. We're going to see Cushing syndrome later on, so this is important stuff to look through and to think about. But for this exam, we it won't be on on this test, but Cushing syndrome is important to study. I guess what I should say is it's going to come up in other modules and it will be testable in future modules, but for this module, it's not going to be on the exam. So it wouldn't hurt you to go ahead and start studying this and looking at it, but to go ahead and know the definition of Cushing syndrome and what all the adverse effects are associated with Cushing syndrome. So you have the buffalo hump and moon face are the two. So it's a fat distribution, where you actually get more fat on the upper part of the back, and then you have your face becomes more fat deposition and becomes has a moon face like appearance. But anyways, and then there's a whole bunch of other things that can happen as well: weight gain, fluid retention, edema, etc. So yeah, that's kind of and hopefully that wasn't too confusing. But so it's good to study, but it won't be on this exam. It'll be in future module exams. So hopefully that's clear for everybody. And you'll notice too, it can cause diabetes mellitus as well. So anyways, a lot of good stuff here. Next up, we have FSH. So a few different preparations here of that, where it's sourced from. Mechanism of action is going to depend on the male and female, but they basically both have a reproductive focus. So related to that, its uses, you'll see them, they have reproductive uses, so infertility and then polycystic ovarian syndrome. Adverse effects, specifically for women, multiple births and ovarian enlargement. Next up, we have LH, the luteinizing hormone. This one's going to be FYI for this exam. Don't stress about studying the LH for this exam. Next up, we have prolactin and related preparations. This one, again, just as FYI, you can just go ahead and read through this. Just note here, though, too, that this is important, that there was an error in the book that I pulled these slides from. So they had dopamine antagonist, but that's why it's in red. It's a dopamine agonist. Bromocriptine and carbidoline are dopamine agonists. So please make sure you note that. We'll be coming up to those later. Again, FYI for my exam here. Don't stress too much about this slide. Please do study, I mentioned already, the bromocriptine and carbidoline. Those inhibit prolactin release, and like I said up here, they are dopamine agonists. So those can help women if they want to inhibit lactation, if they're not pregnant, or if they're and then prevention of breast tenderness, again, if they're not breastfeeding. It can also help with amenorrhea and galactorrhea. So associated with some certain types of cancers, pituitary cancers specifically. So it has some kind of niche uses, not something you'll probably see everywhere, but they're kind of rarely used drugs. And I don't know, it just kind of depends on where you end up practicing. So you notice here too, again, please correct this typo. These are dopamine agonists, these two medications. Uses, adverse effects, and contraindications. Next up, we have posterior pituitary hormones and related drugs. These two are going to be important and going to be testable as far as this exam goes. So desmopressin and oxytocin. So just a quick note here, and this is something that hopefully won't confuse you guys. It's confused some students in the past. So desmopressin is the name of the medication. So this is the drug here that you can prescribe and use, but it's the same thing, or it's a synthetic analog is the proper way of saying it. It's of vasopressin, which vasopressin is also known as, aka ADH, antidiuretic hormone. So antidiuretic hormone is the same as vasopressin, and the pharmacological product is called desmopressin. So the reason I was kind of explicit with that, and I have all the different terms on here, is because out in practice in hospitals, etc., you will hear people interchange these terms. And so my wife, for example, is one that she'll talking about vasopressin, and I'm like, wait, don't you mean desmopressin? She's like, you know what I mean? Whatever, because she's talking about prescribing or using vasopressin or ADH, whatever. So depending on the practitioner, clinician and stuff, you may hear them interchangeable. But desmopressin is the one that you will be, prescribing is the one. So, and desmopressin is used for any time there is an absence of ADH. So for example, diabetes insipidus, abbreviated DI. This is where you get the polys. So you get polydipsia, polyuria. So polydipsia just means increased thirst. Polyuria means increased urination, and then hypernatremia can be a concern. There are also disorders from excess amounts of ADH. So up here is where, so diabetes insipidus is where there's an absence of ADH or not enough ADH. And then there are disorders where you have too much ADH. And again, I kind of slowed down there or made that explicit because in the past students have gotten these confused and they've had, when they're studying, they've had diabetes insipidus mixed up with SIADH, which is the syndrome of inappropriate antidiuretic hormone. So please keep those straight for studying purposes. This slide is where there's excessive amounts of ADH. So this is where instead of having hypernatremia, you can have hyponatremia because basically your body's too dilute. So you have the hyponatremia. So anyways, then this can be, SIADH is what it's called. And you guys may remember this, that you may see the SIADH as a side effect for some drugs. We have some list here that you can sometimes, it can be an adverse effect of some drugs. The narcotics are one, too, that it's kind of a big class there, but that can be an issue, especially if people abuse it or on a longer term. And then also knows CNS injury, and then things like tuberculosis can cause SIADH. So, and SIADH, again, is where you have excess amounts of ADH. This one is just more FYI, but it's just basically what regulates ADH. So, just read through that, but don't stress too much about it for studying for my test. Mechanism of action, again, this is for ADH. You can just read through this, but it's just more for pathophysiology. Here's the mechanism of desmopressin, which is a little bit different, and so this is good for studying purposes. So again, hopefully this isn't confusing. I tried to change it a little bit from last year's feedback to make it hopefully more clear cut. But now we have, so this is desmopressin, so please study this mechanism of action. So like we said before, this is an analog of ADH, and it's does a couple big things here. So it first off, we have that it increases water permeability, resulting in decreased urine volume and increased urine osmolality is one. It's also, it has an effect on the von Willebrand factor, factor 8, and TPA. So all of this means that it can shorten bleeding time. So it's good for people who have hemophilia. So you notice the uses here. So hemophilia is listed throughout here. It's also, because of its first mechanism of action, it is good at treating or helping treat diabetes insipidus. Because if you remember from previous slides, let's jump back. Beep, 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 beep. Diabetes insipidus is where a person has an absence of ADH. So, so this is desmopressin also used for that. So diabetes insipidus use, and then hemophilia disorders uses, so that you can have those as the two kind of main uses. And then the third one is going to be nocturnal enuresis, which is also known as bedwetting. So those are going to be your three main uses here for desmopressin for studying purposes. Don't stress about by injection, nasal solution, nasal spray, tablets. I just put that more as FYI, but had some students in the past ask me if I want you to memorize those. For testing purposes, no, you do not need to memorize those. However, for testing purposes, like I said, three uses: diabetes insipidus, hemophilia, and then the nocturnal enuresis. So please, that's what I'll take on point of this slide here. And then this is just a note that thiazides we talked about before, they can be used to treat peripheral, which is nephrogenic diabetes insipidus. So had some students ask me about that in the past, but so that's a specific type of diabetes insipidus. So you may see that from your other courses and other instructors when they're talking about that. But anyway, so desmopressin uses, hopefully those are straight this year for everybody. Adverse reactions. So long list of adverse reactions here. Big one is going to be hyponatremia. So definitely put a star by that. Very common. Something you're going to always be mindful of when you're giving this, especially when you're giving an IV, higher doses, longer term. So hyponatremia is going to be something. Other than that, you notice you have some CNS adverse effects, some GI adverse effects, some other things to be concerned with, but definitely the, and then down here we have the rare but serious ones are down here. The other one to be concerned with that is not at the top of the list here as far as higher percentages, you'll notice here it has decreased blood pressure. So hypotension can be an issue here and can be problematic for some patients. So that's something also to be mindful of. So hyponatremia and then hypotension. Those are going to be the couple ones that you want to definitely highlight on this slide and make sure you study. Next up, we have drugs that increase the secretion or action of ADH. This is just kind of more FYI, but this is something to think about. You know, when you're talking about drug interactions, there'll also be drug disease interactions. So this would be the this slide would be categorized as drug disease interactions. So just read through that. It's not. It's just kind of an FYI, but it's, you know, it can still be important. And then we also have some medications that decrease the secretion or action of ADH. The big one, or depending on your patient population, is ethanol or alcohol. And then lithium and demeclocycline can decrease. So because of that, those can actually help to treat SIADH. So lithium we haven't talked about yet. It's going to be in the psych module because it helps with treat bipolar disorder or mood disorder. But anyway, so yeah, we'll see that one again, but it can be used for SIADH. And then the demeclocycline, you guys will hopefully remember from way back when in 2017. No, it is a tetracycline-like antibiotic. So it's a tetracycline derivative antibiotic. So it's one of those that its main use is going to be infections, but then the SIADH is actually an off-label use. So it'll be one that, and you'll notice too, it is nephrotoxic. So you do have to be kind of cautious with it, and it's usually not first line. Next up, we have ADH antagonists. These are convaptan and tolvaptan. Got to slow down to say those. I always want to say Compatan, but anyways, that's not how you say it. It's convaptan. All right, there's a P in there, but anyways, these kind of niche uses, just basically take home point. These can be helped to treat hyponatremia, is just what you have to worry about there. Just basically because its mechanism of action, it increases serum sodium concentrations. So hyponatremia is what is used for. Oxytocin. So this one is used to induce labor and stimulate uterine contractions. So we're definitely going to spend more time on this one in the OB-GYN module. Part 2. So we're going to go ahead and stop there for this first part. Hopefully everything was clear and made more sense than last year. If not, email me, please, if you have any questions or concerns or comments or feedback or whatever. And thank you guys for your time and attention. I will talk to you guys later. Bye.